Okay, so this is where I work, Tan Tock Seng Hospital, and that's a portrait of Mr. Tan Tock Seng, who donated the sum of money 177 years ago for setting up this hospital to serve the poor and the needy. And today, I'm proud to be carrying on with that philosophy to be able to provide care to anyone and everyone who needs my help, regardless of their socioeconomic status. Okay, I'll be talking about headaches and dizziness today. I just want to give you a bit of background about myself and my interests. So I'm an ENT doctor, but the E is a lot larger than the N and the T because I focus on conditions, diseases of the ears. And the two big things that are of interest to me would be patients with hearing problems and balance disorders. So I run the multidisciplinary balance clinic at the Tan Tock Seng Hospital, where we see patients with complex balance and dizziness problems. That happens only once a fortnight, but even in my regular general clinic, I do see large number of patients with dizziness and balance problems. And on average, in a week would easily be 20 patients. Of course, this was before some of the current restrictions with the latest COVID situation, but the workload is slowly getting back to normal. I have to say that managing patients with dizziness is a team effort. It's not just me. In fact, I wouldn't be able to achieve all the good work without the help of my colleagues, other physicians, doctors from neurology, from psychiatry, from elderly medicine, allied health professionals, from physiotherapy, audiology, psychologists, and even colleagues from TCM. Some of you may not be aware that Tan Tock Seng Hospital actually has a TCM department, right? So I like to say that it's all about teamwork and group work, and we learn a lot from each other. It's important to know what we know and also our limitations, because my colleagues in other specialties, they do have skills and knowledge that I do not have. Right, so over the years, since I moved to Singapore 10 years ago, I have tried to do my part to educate the public on dizziness conditions. So there have been a few articles in the Straits Times mainly over the years, example of some of them. So if you subscribe to the Straits Times, you could try and look up some of these articles written by myself. And also in the Chinese and the Malay press. Okay, now, so before I move on into talking about headache and dizziness, right? I think it's important for my patients and the general public to understand certain concepts. And I think the most important concept is this thing about symptoms versus diagnosis. Quite often they are used interchangeably. Sometimes healthcare professionals could be guilty of this as well. But I think if we can try and differentiate these two important concepts, then it would help both the patients and the healthcare professionals in understanding management. What are we trying to achieve? All right. So let's start with symptoms, right? Symptoms are physical or mental, and they are usually unpleasant experiences by patients that indicate that they have an underlying medical condition or disease. For example, patients will complain of having headaches. They have a cough, right? They have pain. They complain of weakness, numbness, forgetfulness, tiredness. So for example, if a patient has a cough, right? The question is, have they got a lung infection, a chest infection, pneumonia, or have they got a throat infection, right? Sore throat. And in the current climate, the first thing that everybody would think about is, oh, has this person got COVID, right? So it's about what medical condition they have that would explain the symptoms that they are experiencing, right? So patients come to see us, the doctors, with symptoms. I have this, I have that. or the doctor had to ask the patients, oh, what are the things that are bothering you? And the diagnosis, right, would actually mean the actual medical condition or disease that would explain why the patients are experiencing those symptoms. All right. So as a doctor, I've been trained from day one to talk to patients, right? What we say, take a history, right? Find out from the patient what is troubling them and asking detailed questions, and then try to rule in and rule out the possible medical conditions that would explain what's happening to them, all right? And then moving on to my next slide. At this point, I'd like to share a bit of my philosophy as a doctor, because I think it's helpful and to my patients, and it has enabled me to help many of my patients get better. So this concept of disease versus illness, again, often used interchangeably by most people and even doctors to a certain extent. So who is this gentleman? He's Leon Eisenberg, who is a child psychiatrist from the Harvard Medical School. You know, he's from a different era, as we can see. He's retired not too long ago. And he was the one who described disease as, you know, actually not him, but the term disease historically came from the term dis-ease, right? That means the patient is not at ease, dis-ease. And when we talk about the concept of disease, it's usually to refer to the concept about dealing with the pathology that doctors are trained to identify and manage, meaning the medical condition, right? The diagnosis. Illness, on the other hand, refers to the impact of the disease and its symptoms on the patient's well-being and quality of life, including on how they function within their families, social functioning, and professional functioning. And I think this is a very important thing to bear in mind, that illness goes way beyond the disease. And essentially, it would be what the patients are interested in. Doctors tend to focus on the disease, but what matters to the patient is the illness. How do their disease affect them and their functioning? So it's important to, number one, get the correct disease diagnosis to begin with. But as a healthcare worker, as a doctor, when I'm treating the patient, it's about treating the illness, treating their symptoms, and not just focusing on the disease alone, right? And who is this gentleman? That's another doctor, Edward Livingston Trudeau, again from a different era. But he's the one who came up with this quotation, right? The role of a doctor: to cure sometimes, to relieve often, and to comfort always. And these are words that are actually very true, because as a doctor, I think any doctor would tell you that this is the truth when we practice day to day, that we don't get to cure all our patients all the time, right? But even though we are not able to cure all our patients, we should be able to relieve their symptoms most of the time, and at the very least to provide comfort to them, all right? And this is something I hold very strongly in my heart when I'm dealing with the patients. What am I trying to achieve with them? Okay. Now, so as I said earlier, making the correct diagnosis is crucial. And the simple reason is that different medical conditions have different treatment options. So if you get the diagnosis wrong, if the doctor gets it wrong, and then you're going to provide the wrong treatment, and that's not going to work or work very well to help alleviate the patient's symptoms. All right. So before you can treat the medical condition, you need to make the correct diagnosis. So these are some of the aims within healthcare. Firstly, is to prevent, i.e. to stop the disease before the illness can occur. Is to cure, is to make the disease and illness go away permanently, if possible. And if that's not possible, if we can't cure the patient, is to control and manage the illness, right? And to prevent future complications as well, right? So it's important, I think, both for healthcare workers and also patients to have this broad overview of what we are trying to achieve in healthcare, right? It's not always about cure, because that's not always possible. And then when we talk about control and management of illness, is about minimizing, reducing the symptoms, prevent future complications, right? Minimize negative impact of the disease on the patient's quality of life, and to allow them to return to their function. And of course, these three aims are not mutually exclusive. You know, anytime we treat a patient, we got to have these three aims in mind as far as possible. And the proportion that we do in each depends on the medical condition. Okay. Now, when we talk about healing the patient, right? And that's what patients want. When the patients come to us, they want to be healed. They want to get better. Where possible, disease prevention is always best. Prevention is better than cure. And as a doctor, I strongly believe in that. Cure the disease and the illness when and if possible. Otherwise, control and manage the disease and illness. Suppress the symptoms once they occur. Prevent the symptoms, even better, right? If you could do something to even stop the symptoms from happening. And this would include reducing the frequency and the intensity of the symptoms. So I'm introducing all these concepts because when it comes to management of headache and dizziness, a lot of these concepts would have to come in. And very importantly, as I mentioned earlier, it's very important to aim to preserve and restore patients' well-being, their function, their quality of life, i.e., we try to minimize the impact of the disease on patients' lives. Now, very often when I see patients with dizziness, right, a lot of them complain of vertigo. At this point, the most important thing, the take-home message for everyone, is to understand that vertigo or dizziness, these are symptoms, right? Not the diagnosis. Because 9 out of 10 patients that sees me, in fact, most of my patients would have seen other doctors before, and they'll come to me and say, "Doctor, I've been diagnosed with vertigo. Can you cure my vertigo, please?" And when I engage them further and ask them, have you been told what's causing your vertigo? A lot of the time they say, not really, or they've been told things that they don't really understand. And I think that may reflect a failure of what we do as doctors sometimes. If patients were to go home with the understanding that vertigo is their diagnosis, right, then I think we're not going to achieve much with them. In order to get their vertigo, get their dizziness, or even headaches better, they need to have a diagnosis first, the medical condition that is causing the symptoms, right? So let's start with the definition of vertigo. The definition of vertigo is very simple. It's the perception of movement where there is none, okay? Now, this perception, you can either perceive it internally or externally. So what do I mean by that? Externally, it means that the patient feels that the room or the surrounding is moving. Internally, they feel that the room is not moving, but inside the head, there's movement. And this movement can be 2 types. And sometimes patients have both. It could be spinning or non-spinning. Very common, patient will tell me, oh, they feel that the room is spinning. So that would mean that they are experiencing external spinning or rotatory vertigo. Another common one is when the patient tells me, oh, the room is not spinning, but they feel that they are moving inside the head. They feel that they are rocking, for example. They feel that there's a rocking sensation in the body. And most of the time, when someone observes the patient, they are not rocking, but the patient feel that they are rocking inside. So the rocking is non-spinning. So they then have an internal non-spinning sort of vertigo, right? So there are like 4 different types of vertigo. And don't worry, you don't have to memorize these 4 types. I think it's for the doctor to ask you to describe what you mean by vertigo, right? And it's important not to mislabel other form of dizziness because there are many other symptoms of dizziness. For example, feeling lightheaded, right? That's not vertigo, and usually nothing to do with the ear, right? Probably the commonest reason why patients have lightheadedness may be over-treatment of their high blood pressure. I do see that quite frequently, but anyway, that's a topic for another day. So I would have to say that it's not useful for patients to be labeled as having chronic vertigo. We know that, the patient knows that they have vertigo for a long time. And just telling them that, yeah, your diagnosis is chronic vertigo, that is not helpful to anyone, all right? Or for that matter, chronic dizziness. I think the patients know that already. They are having dizziness for a long time, right? Or chronic giddiness. Very, very common labels that patients have. And often the patients will take this as their diagnosis, right? So today we're going to move beyond that, right? As I said earlier, I'm starting to sound like a broken record now. It's so important to get the diagnosis correct, okay? And that's my responsibility to you as your doctor, right? And I'm sure all other doctors would say the same to you. That's what we've been trained to do. And then because it's only by making the correct diagnosis, we can explain to you why you are suffering from vertigo, dizziness, headaches, and only then can we treat it, right? Right, so again, this is just a summary of everything that I said, right? That when we are managing patients with dizziness, vertigo, headaches, these are some of the aims: prevention, cure, control, and manage. And of course, important to get the correct diagnosis. Okay, at this point, I'd like to just give you a very brief introduction to the balance system. I do this because I understand from the vast majority of the my patients, that they generally have very limited understanding about what the balance system is and how it works. And as part of getting them better, a lot of my patients do describe that, yes, them understanding how the balance system works in a very simplified way help them appreciate what their condition is about, right? So the first thing I ask my patients to be, are you aware that you have a sixth sense? At this point, a lot of them will give me a very puzzled look, right? Sixth sense, what is he talking about, right? Some of them will even think within the context of Singapore and in Asia, is it the ability to, I don't know, see ghosts or sense the spirit? Sometimes they say that. So it's interesting when people talk about your sixth sense, what comes to people's mind, right? Is seeing the supernatural. No, I'm not talking about that sixth sense. That may exist. The ability to sense those sort of things may exist for some people, but again, that's a topic for another day, right? So before we talk about our sixth sense, let's talk about our five senses first, right? Because that's the thing we talk about, five senses. What are our five senses? I'm sure you know, right? It's about our sense of hearing, sense of vision, sense of smell, taste, and lastly, touch, pain, and temperature sensing. That's largely through the skin, all right? So what then is our sixth sense? One patient even, in fact, more than a patient brought up, oh, is it that movie from, I don't know, I think it's more than 10 years ago, The Sixth Sense? Some of you may well have seen it. Bruce Willis was the main actor there. They say, oh, is that what you mean? Nope, again. So when I talk about the sixth sense, we are referring to the ear. I think everyone knows that the ear is involved for hearing, right? How do we hear? We do that, right? But actually, the ear is a very special organ because it has two sensory functions. It's the only organ with two sensory functions: hearing and balance. Okay, again, not something to scare you, but just to show you what the ear looks like when you cut across it. A lot of us are familiar with the outside of the earlobe, and the ear canal, and everyone knows that inside at the end of the ear canal, there's the eardrum. But it's behind the eardrum, that's where all the important hardware, the organs are. And if you see this structure behind the eardrum, something that looks like a snail, I'm sure all of you have seen the diagram of this thing that looks like a snail behind the eardrum. That is our hearing and balance organs, two organs joined together. So if you look at the label, that part that says cochlea, that looks like the shell of the snail, that is the organ of hearing, okay? Next to it, there's something labeled vestibule. That is the organ of balance. Okay. And at this point, I just want to state that the balance of organ is actually very sophisticated because there are 5 components to it. Okay. And I'm not going to tell you what the 5 components are because probably not important for this talk. And just another diagram of the ear, the cochlea, and the vestibule, the hearing and the balance part. Just to let you know that these organs, they are surrounded by very, very hard bone. In fact, the strongest bone in the human body. But within this bone, there are channels that are filled with liquid and also nerve fibers and nerve endings. So the nerve endings in the cochlea would detect sound and the nerve endings in the vestibule would detect movement. All right. And actually, at this point, I just like to state that in order for us to balance, to not fall down, for us to walk upright, our body needs sensory inputs, not just from the vestibule, which is the balance part of the ear, but also visual input and also somatosensory. By that, I mean the touch, pressure, and joint proprioception. These are largely located in the legs, in the ankle. It's about sensors there that tells us, how the floor feels like. Is it smooth, slippery? Is there a gradient? Right? So actually, our balance system is quite complex in that sense because it relies on 3 sensory input, 3 signals from different parts of the body. The good news is all of this is happening in the background. We don't have to think about how do we maintain balance, right? It happens, it just works. The trouble is when they don't work well, that's when we start to be aware of the symptoms when they malfunction. At this point, just something of interest, again, not for you to memorize. When I ask this question, I always get very different answers. I always ask this question of how many degrees of freedom are there in the head motion? Meaning, what are the different directions of movement the head is capable of? I don't know. One of the things I miss about having a live audience is this sort of real-time interaction, right? Which is not possible on the Zoom meeting. So something that I definitely look forward to in the future is to be able to give talks to a live audience again. But of course, at the same time, a Zoom talk enable reaching out to a wider audience, people who cannot make it to the center perhaps, or even people who are not in Singapore. So how many of you would say 2, 3, 4? These are the common answers that I get. Actually, 6, all right? So 3 of them are rotational. For example, I'll just demonstrate to you, even rotating. That means it's on this is one axis, second axis, and this is a third axis. 3 axes of movement. Translational means linear. That means it's not rotating, right? So it'll be like this, and up and down, all right? 6 degrees of freedom. Okay, this is just an interesting point just to let you know that our balance organs, as I told you, it has 5 components, and the reason it has 5 components is to detect the 6 style of movements that our head are capable of. So it's a very sophisticated organ, and I will stop there. All right. Of course, if I'm giving talks to like doctors, I will go into further details about how the balance organs actually work. Okay. Now, at this point, I'd like to quickly mention some of the common medical conditions that causes vertigo and focus on one of them, which is often not that well known. Okay, let me start with the ones that I think for those of you in the audience, I don't know how many of you have suffered from dizziness, vertigo, headaches. Some of you may have, some of you may have family members who have these symptoms. But if you do, or your family members have them, this is something that you may have come across or been given the diagnosis, Bppv, which stands for benign paroxysmal positional vertigo, vestibular neuronitis, Meniere's disease. The 4th one, vestibular migraine. I'm going to spend a bit more time talking about this because this is the one that is not so well known, both by the general public and also among many doctors. And talk a bit about motion sickness because that is actually from my patients is extremely common. Okay, let's just talk about Bppv first. just very quickly, because these are conditions that most of you would have heard about and many doctors are already familiar, right? But typically, patients with Bppv, they get very brief spells, often described as less than a minute, but in my patients, it's often 10 to 15 seconds of external spinning. That means the room is spinning upon lying down and turning the head to one particular side. It could be the right or left. And often they may get the symptoms at the hairdresser, or if they're trying to reach for something on the high shelf, this sort of motion, or just at night when they're in bed, right? And often they get repeated episodes over several days or several weeks. And not infrequently, this can resolve by itself, but it may recur. And really the cause of this is that you can have crystals from your balance organs. I mentioned earlier that the balance organs have 5 components. 2 of the components contain crystals, 3 of them don't. So if the crystals from these 2 compartments were to break free and enter the other 3 compartments, essentially that's when you get Bppv, okay? And the treatment, if you see a doctor or a physio, is for us to do a maneuver to move the crystals back to the compartment that is supposed to contain the crystal. So it's not a very complex condition. And I would say that all ENT doctors and perhaps many GPs as well are familiar with this, and they should have no problem diagnosing it. Although the treatment, the maneuver, perhaps, yeah, all ENT doctors can do it, but many physiotherapists can perform this as well. Okay. Important for this condition, earlier I talked about cure, right? This is one condition that you can cure, but the cure may not be permanent because the condition can recur in the future. All right. So not uncommon for that. Yeah. Okay. The second one would be vestibular neuronitis. This is when the patient gets a single attack of severe vertigo with nausea and vomiting, lasting from a few hours to a few days. So one attack only, right? You shouldn't be getting recurrent attacks of this. This is a condition where there's inflammation in your balance nerve, okay? And this vertigo would often be followed by a period of unsteadiness that can last days to weeks. But most patients, especially the younger patients, eventually the vertigo disappears completely, the imbalance disappears completely, right? And as I've said, it's caused by inflammation of your balance nerve. Treatment in the very early stage, patients, they may have severe nausea, vomiting, they may turn up to the emergency department, seeing a GP, and usually you get an injection to suppress the vertigo. In the later stage, if the patients don't compensate and they continue to get imbalance, seeing a physio for so-called vestibular rehabilitation therapy would be very good at correcting these symptoms of imbalance. So this is actually not that common. Okay. Next would be a condition called Meniere's disease. So I think many of my patients who come and see me would have heard about this condition and may have even been diagnosed with this condition. Is where they get repeated attacks of vertigo associated with hearing loss, tinnitus, and blockage or fullness in one ear. The attacks can last minutes to an hour, and they get repeated attacks. And usually they get clustering of these vertigo attacks. It means they may get it over several days in a row, several weeks in a row. Then they can go for long periods, weeks, sometimes months, without any further symptoms, and then the symptoms can come back. And usually the hearing loss, the tinnitus, and the blockage, the fullness in the ear, they resolve between the attacks of the vertigo. And longer term, the patients tend to have progressive hearing loss, and they end up with permanent deafness in one ear usually. And the cause of this condition is thought to be due to high pressure in the balance organ, all right, and also the hearing organ is like having high blood pressure in the ear. And for this condition, there isn't really a cure. It's about control and management of the symptoms. And in terms of treatment, medication-wise, there are 2 types of medication, one to prevent the condition and one to relieve the conditions. And I've given some examples there, but again, not for you to remember, okay? Now, the condition that I want to focus on today is something called vestibular migraine. And really, the best way to describe this condition is that it is the elephant in the room. The reason why I call it the elephant in the room is that this condition is actually Well, I wouldn't say extremely, but I would say it's very common and unfortunately underdiagnosed. And a lot of my patients would have suffered from symptoms of this condition for years, for decades before the diagnosis is made. And unfortunately, until the diagnosis is made, then the patients will not get better. The oldest patient that I have when I make the diagnosis for the first time is a 76-year-old lady who's been having symptoms for 60 years, 60, ever since she was in secondary school. Yeah, and she was extremely grateful when the diagnosis was made finally and control the symptoms. And then I think on one of the clinic visits, she came up and gave me a big hug and say, "Thank you, doctor. For the first time in my life, I've gone 6 months without any dizziness." So I think it can be quite debilitating and can really affect patients' quality of life. So what is vestibular migraine? Perhaps we take a step back and talk about migraine to begin with. Okay, what is migraine? I mean, do you have migraine? Okay, to decide whether you have migraine, this is a question that I would ask my patients. Have you had the following in your life? Okay, let's start with headaches. Have you had headaches with at least 2 of these 4 characteristics? Number 1 is that the headache is unilateral. Unilateral meaning it's on one side of the head. Is it a pulsating or throbbing sort of headache? That means it comes in waves. Is it of at least moderate or severe intensity? Moderate, okay, when we talk about severity of headache or dizziness, mild, moderate, and severe. Mild means that, yeah, it's there, but you can get on to do whatever you are supposed to be doing that day. You are working, you got housework, you can carry on. Moderate means that whatever you are supposed to do that day, you could carry on, but you really have to slow down and you're not as productive that day. That is moderate. Severe means you have to stop. If you're doing your housework, you're cooking, and you get it, and it's bad enough that you have to stop and rest or sleep, that is severe. And this headache is made worse by physical activities, things like even walking or climbing stairs. So if you get the headache, and as you're walking around the house doing housework, and that makes it worse, that is one of the 4 characteristics. So if you get repeated attacks of headaches with at least 2 out of 4, many patients have 4 out of 4, that is a migraine attack. And also during the headache attacks, you need to have either nausea or vomiting, or sensitivity to light or sound, or some patients even describe sensitivity to smell. And if you had 5 attacks of this sort of headaches in your life, lasting from between 4 to 72 hours in your lifetime, so then you have migraine. Okay, so some of the older patients that I know, they may have had this sort of headaches when they are younger, especially the ladies. They'll tell me before the menopause, they have these headaches. After the menopause, they don't have it. So they don't have migraine headaches anymore, but they have migraine. Okay, migraine is the diagnosis, the medical condition. The migraine headaches, that is a symptom. Okay, now, what then is vestibular migraine? Vestibular migraine, I think the best way to look at it, it refers to a, okay, first of all, when we talk about migraine, right, how common is migraine? Depending on the different studies that are done in different countries, it ranges anything from 10 to 30% of the population having migraine. Up to 1/3 of everybody around us have migraine. But of course, the severity of the migraine is highly variable. We also know that the vast majority of migraine, especially those who get milder symptoms, infrequent symptoms, they get the symptom once a year, right? They sleep, they rest it off, they get better. Most of these patients will not even have seen a doctor or have the diagnosis made. So again, many other studies have shown that, up to 90% of patients with migraine never get it diagnosed. Usually the ones with severe and frequent symptoms, they would get the diagnosis. But the one with infrequent, sometimes severe but infrequent, they may never get it diagnosed. So the best way to look at vestibular migraine is a subgroup of patients with migraine who not only get headaches, but they get vertigo or dizziness as well. And often the dizziness and vertigo can be very severe. So let me ask if you get the following symptoms. Okay, do you get vertigo? And this vertigo can be any of the 4 types I mentioned earlier. It can be internal or external. It can be spinning or non-spinning. And the vertigo can either be spontaneous, it just happened out of the blue, right? Or more commonly for most of my patients is provoked. And it's provoked by the following few things. Changing the head position. So they just find that, oh, just changing the head position. Somebody is calling them and they take, and just turning the head like this. That can bring on the vertigo. It can also be provoked by repetitive head movement, that means repeated head movement. And the typical example would be when they're trying to cross the road, looking right, left, or driving the car or even the bicycle, because you have to check to see if there are cars, vehicles around you. So those sort of movements, or even in the shopping center, they're window shopping, then they're moving the head repetitively. And the last one is this vertigo is provoked by visual stimulus, meaning they are in an environment that is quite stimulating. For example, if they're in a busy place like an MRT station, in a market, even supermarket, a lot of people moving around them, walking down the supermarket aisles because it's very visually stimulating, or even watching a movie, right? And they get the vertigo. Some patients, besides vertigo, they also get dizziness in the form of visual spatial disorientation. That means they kind of like have a lot of difficulty telling where things are, where the floor is. When they walk, they feel, oh, the floor is not quite where it's supposed to be. It's an interesting symptom that some patients may have difficulty trying to explain, but when I try to help patients describe, often, yeah, they have this visual spatial disorientation. And then, now, for it to be vestibular migraine, not only do you get these symptoms, but at least half the time when you get these symptoms, you have at least 1 out of these 3 migraine symptoms. Number 1 itself is getting the migraine headaches. Number 2, you may not have the migraine headaches when you get the attacks, but you are sensitive to light and sound. And if you happen to be in a bright environment, or somewhere noisy, there's construction work going on next door, that makes the dizziness worse. And some patients also describe visual aura, visual disturbance, blurring of vision, dots, lines, waviness in the vision during or before the attack of the vertigo. So if you have any one of these 3, that makes it a migraine dizziness. And if you have had at least 5 episodes of this sort of dizziness, lasting between 5 minutes and 72 hours in your life, that is vestibular migraine. Okay, this is not my diagnostic criteria. This is something that is established and recognized internationally. Okay, so I'm using very, very strict criteria for it. But despite the criteria being very strict, when I apply the criteria, when I ask patients very carefully, a lot of my patients fall into this category. Okay, now, oh yeah, and the last one, sorry, I forgot to mention that the patients have a history of current, that means they still get migraine sort of headaches, or previously when they are younger, they were getting migraine headaches. Okay, so important to note that you need not have the migraine headaches together with the vertigo for it to be vestibular migraine. That's according to the diagnostic criteria. Of course, for the doctor, it's easier if whenever you get the vertigo, you get migraine headaches, easier for the doctors to make the link. Now, there are a few myths about, or misunderstandings about migraine, okay? Now, the first and the most important, and I think this applies not just for the general public, for even many doctors, right? It's important to understand that migraine is more than just headaches, much, much more than that. Migraine is something inherited, unfortunately, it's genetic. And many migraine patients, they will realize that often they have other family members with migraine, but the symptoms that they get may be quite variable between different family members. And the symptoms that the patients experience would depend on which part of the brain is affected. There are different forms of migraine. For example, we have a group of migraine patients where they get visual disturbance, where they lose the vision in one eye during the migraine attack, and then for the vision to come back, That is called ocular migraine. We also have patients with abdominal pain, tummy pain during the migraine attacks, and that's also a form of migraine. We have some patients who are extremely sensitive in the skin. That means if you were to touch them during the migraine attacks, yeah, that is called allodynia, right? Another form of migraine. So vestibular migraine is another form of migraine where dizziness, vertigo is a big part of the symptoms and not just the headaches, okay? Let's move on. So as I said, people with migraine, it's unfortunate that they are born with a brain that is sensitive, or what we call a hyper-excitable brain, okay? It's how the brain is wired. It's important to understand that the symptoms of migraine can evolve as we go through different phases of life. And any one of you who are older ladies, right, if you are postmenopausal, it's important to appreciate that if you were getting a lot of headaches before your menopause, it's very common for the headaches to get better or even disappear after your menopause. So many of my patients would celebrate and say, yes, I had my menopause 10 years ago, headache went away, my migraine is cured. But guess what, doctor? For the last 8 years, I've been getting recurrent vertigo. What is going on? So the unfortunate thing is that the migraine is there, the headaches have gone away, but they're now getting the disease form of migraine, so to speak. All right. So the management of migraine is to try and make your brain less sensitive to the sensory stimulation, right? Because a lot of patients with migraine, they're very sensitive to sensory stimulation. And how many sensory stimulation do we have? How many senses? If you've been paying attention, 5? No, 6, right? As I explained to you earlier, right? And some of the common misconceptions about vestibular migraine is that the giddiness or the headache or the vertigo must occur concurrently with the headaches. No, that's not necessary. And that's not because I say so. And it's based on the diagnostic criteria, right? And one thing to bear in mind, I've noticed in my older patients, very often, even if they do get headache together with their dizziness, they no longer describe it as the headache on one side, the throbbing side of headache, but they describe it as a head heaviness all over, fogginess in the head. They find it hard to concentrate on anything, right? The eyes feel heavy, the brain feel heavy, right? That is very, very common. Yeah, these are some of the clues that would suggest that you have vestibular migraine, right? If you have vertigo or dizziness provoked by lack of sleep, periods of stress or emotional disturbance, consumption of food known to trigger migraine, and some of the common examples would include caffeine, salty food, food with high level of MSG, chocolate, cheese, especially the mature cheese, citrus fruits, alcohol. Very common, but important to bear in mind that not every patient are sensitive to all these foods. Some would say, oh, one tiny piece of chocolate would set off the migraine. Some patients can eat the whole bar of chocolate and they're okay. So it doesn't mean that you got migraine, you are not allowed to eat chocolate. You got to ask yourself, is this particular food a trigger for my migraine? If it is, then of course, it would make sense to minimize your intake. Importantly for the ladies, and that would be half the population, right? A lot of patients will find that their headache or their dizziness symptoms would tend to be worse during or before the menses. And perimenopause, as they're going through the menopause, the symptoms can get worse, but frequently after the menopause, the headaches gets better. Another important thing, living in our dry, not dry, hot climate, right? But we are going through the dry season now, dehydration. That is a very powerful trigger for migraine, and it's something that is so easily correctable, right? So if you have migraine, prone to migraine, make sure you're well hydrated all the time, and that goes a long way in preventing the migraine attacks. The other clues for vestibular migraine would be if you find that you have vertigo or dizziness and resting, sleeping, and you recover from it, that is a powerful clue. And you will find that during the attacks, when you're giddy, you are not only sensitive to light, sound, but even smell, sensitive to heat, or you want to touch. You don't like it when people touch you when you're getting the dizziness attack. A lot of that, my younger patients, ladies, during their menses, they would describe a high level of irritability during or before the menses. history of motion sickness is very interesting, right? Virtually all my patients with migraine and vestibular migraine, they will tell me that since young, they've been intolerant of being in a vehicle that is moving very jerkily. And if you ask carefully, often there will be other family members with chronic headaches and dizziness. When I talk about sensitivity to visual sensitivity, these are the sort of examples, when they look at certain diagrams that may sort of like provoke, make them feel very uncomfortable. And if they stare at it for a while, they may get some dizziness, some headaches. This is visual sensitivity. So the earlier diagram is just diagram, but where do we see this in real life? These are photographs from Tan Tock Seng Hospital. There is a toast box in the atrium and the flooring is like this. And I know that my migraine patients, if they step into toast box in Tan Tock Seng, they will feel a bit, oh, woozy, because the repetitive patterns of the floor, right? And these are other examples. My patients with migraine, vestibular migraine, whenever they walk down certain environment corridors with repetitive patterns, things like this, that will cause them to feel very giddy and provoke their symptoms. Okay. Motion sickness, just want to quickly cover, is very, very common. And the simple explanation would be, it's due to sensory conflicts, right, between your balance organ and what your balance organ is sensing and what your eyes are seeing, right? And usually this happens in a bumpy vehicle. Or it can also happen when you're playing video games, especially if there's a virtual reality component to it. And different individuals have different levels of tolerance to balance sensory inputs mismatch. Now, what is this mismatch I'm talking about? It's about, okay, I think the thing that will trigger motion sickness, right? If you're in a bus or you're in the rear seat passenger and of the car and it's a bumpy journey. And if you think back, if you are prone to motion sickness, you got to ask yourself, when am I prone to the motion sickness? Often it's related to reading when you're in the vehicle. All right. In the past, it's reading a book or newspaper. Nowadays, it's like usually reading your handphone. So the issue has to be when you're reading a book, right? And you're on a bumpy journey, right? As you move, as your body moves, your head moves, your book or your phone moves as well. So what your eyes will be telling your brain is that you're not moving because your book is moving together with you. But during the bumpy journey, your balance organs will be picking up on all this shaky movement and it will be telling your brain that, hey, the ride is very bumpy. So your balance organs are telling the brain it's a bumpy ride, but your eyes is saying, no, it's not bumpy. And the brain doesn't like it, right? And some of us have brains that are intolerant to a mismatch. The ear is telling the brain one thing and the eyes are telling the brain another thing. Those of us who have a high tolerance of that, great, you can be a fighter jets pilot, right? For mere mortals, if you have this intolerance, then yeah, you will get symptoms of motion sickness. And it's extremely common in migraine patients. And the simple treatment for motion sickness is to look outside the vehicle rather than to look into the vehicle or look at the book or a phone. People who drive, right? So even if you are prone to motion sickness, they will tell me that when they are the driver, they don't get motion sickness. And that is true. And the next best thing to being the driver is to be the front seat passenger so that you're looking out. The worst thing you can do is during the car journey, you are the front seat passenger, you keep looking to the back to talk to your friends or family in the back. Then that will increase the chance of you getting motion sickness. And as I've said before, this is very common in patients who are prone to migraine. I just want to play you a quick video of what you may feel because this is the car park at Tan Tock Seng Hospital. And spiral car parks, a lot of patients with motion sensitivity, they don't do very well, right? And this is the spiral car park in Tan Tock Seng Hospital on the ward block. The clinic block is not so bad, right? And so if you find that, whoa, when you go out this spiral car park, you get very dizzy, that is motion sickness, and you may well have migraine to explain why you have it, right? Okay, at this point, I just want to say that for migraine, right? Besides what I mentioned about the triggers, right? Another thing that can really provoke or trigger the symptoms of migraine is when there are emotional or psychological stress. And this is very common, right? For many people. And when a patient is going through a period of psychological emotional stress, they are more likely to get the migraine attacks. The trouble is, it's actually not that easy to elicit these symptoms from your patients, right? You're trying to ask your patient whether they have stress. If you just ask them, do you have stress? Most patients say no, all right? You need to be a bit more sensitive in how you ask it. And part of the problem that we face is that generally in our society, there's a lot of stigma and prejudice for discussing mental health issues, right? Nobody wants to admit that they have mental health issue, that they have stress. People can get very defensive, right? Especially the high-performing, high-flying individuals, right? They don't want to admit that they have stress, they have psychological worries, emotional issues, right? So, and I think it's important that for me as a healthcare, as a doctor, and also for the general public is we need to move beyond this black and white view about mental health problems, right? It's either you have mental health problems or you don't, black and white. And I think if you hold on to those views, it's very hard then, right? And quite often people would accept that someone has mental health issues only when it's very extreme, right? When they have severe depression, severe anxiety, to the point that they cannot function anymore. Then people say, yeah, that one mental health, right? Bad enough that they need to see a psychiatrist, they need to be an antidepressant. Then we accept, yeah, that is mental health, right? Or the patient is suicidal, or the patient was still committed suicide, right? Too late, we missed the boat. So I think it's very sad if we look at mental health issue black and white, yes or no, and it's only yes if by the time you have one of these three things happening. The truth is that as with other medical problems, right, there's a wide range of severity and the intensity and the impact on the patient's life. And wouldn't it be fair to say that the vast majority of us have experienced mental health issues in our life? Because life, it's full of ups and downs, right? We go through periods of happiness, sadness, things bothering us, stress at work, stress at home, family happenings, bereavements. This is all part and parcel of life, right? None of us can escape it. And so which of any one of you would dare to raise your hand and say, oh, I've never been through periods where I'm down, I just emotionally not feeling great, or going through a period and I feel a bit anxious, feeling maybe a bit depressed. It may not be hardcore depression. We've all gone through it, right? And it's important to realize that when you're going through these periods of you're down, right? Emotionally not so good. That's when the migraine is more likely to happen. And for me as a doctor, it's very sensitive when you talk to patients about it. But I think I've developed the skills over time to how to drag this out from the patient to find out what's going on in their life. And I think you need kindness, empathy, be really respectful, be very humble and sincere when you ask the patients about this. And if you are, I think patients can read into that, the non-verbal part of it, communication, and patients will open up and say, yeah, my dizziness, my vertigo started when I was going through a stressful period at work. I was experiencing bereavement, right? And they may not openly tell you that. Now, COVID, right? I think what has that got to do with dizziness? Actually, quite a lot, right? Just today, right? China News Asia, you may look it up later. There was a little commentary by Gregor Lim Lang. Interestingly, he was one of the board members for Brahm Center previously. He's of Irish-German ancestry. Clinical psychologist, a professional, has been living in Singapore for a long time and married to a Singaporean. And just this morning, he shared his thoughts and views about some of the emotional things he has to go through because his mom lives in Germany and he's not seen his mom for 2 years because of COVID, and how recently he managed to make a trip to Germany with all the restrictions and managed to see his mom and how emotional that was, right? So a nice sharing. But I like to use this as an example that I see it in a lot of my patients now. There's a lot of COVID-related mental health issues and some broad categories, but not meant to be comprehensive. Disruption to career and livelihood, disruption to family lives and relationships, and disruption to the things we enjoy. And just to give some examples, career, losing your job, or even if you don't lose your job, drop in income, right? How do you maintain your livelihood, your family life, your children's education, your mortgage for your home? Or sometimes even if you don't lose your job, change in the job scope because you can't carry on doing things the same way with the social distancing. Working from home can be a blessing for some, but also can increase the stress because a lot of my patients say working from home just means that there's no barrier between work and home anymore. Work never stops, right? And so for some of them, they complain that working from home can be doubly stressful, having to supervise the kids at home and then your boss expecting you to work 24 hours. Disruption to family lives and relationships, meeting loved ones during the circuit breaker, yeah, where we couldn't visit our relatives, especially the elderly relatives. If they're ill, they're in hospital, you can't see them. And it's especially bad for those who have families who are overseas, living abroad, myself included. My parents are in Kuala Lumpur, and I've not seen them since Chinese New Year last year. So it's a year and a half since I've seen them. And something for us to empathize, right? Those of us who have families abroad or know people with families abroad, we just empathize with the sort of stress they're facing, not being able to see their family members, or worse, if their family members fall sick. I already have 2 colleagues in my department who have not been able to say goodbye to their mothers who passed away during the COVID time and not being able to attend their funerals, and I think it's probably the worst thing for anyone to go through, not being able to say goodbye to your mom or dad and not being able to pay your last respect, so something for us to be aware of. Now, disruption to your wedding plans or your funeral plans, right? It's funeral, of course, you don't get to pick, right, when you pass away. Weddings, but again, weddings is not that easy to change your plans at short notice. And then disruption to the things we enjoy, our freedom, right? To do what we enjoy, going outside without wearing masks, all the restrictions, traveling overseas, recreational activities, gym, eating out, right? All the things, karaoke, yeah. So I think every one of us are affected in one way or another mentally, right? COVID has a big impact on our mental health and will continue to do so, unfortunately. But hopefully, as the restrictions are lifted, things will improve. So the aims of treatment, I just want to quickly go through, is to treat the illness rather than disease. Education is crucial. And when you treat the patient, it should be a combination of medication, lifestyle and dietary modifications, and to ask the patient, what's the impact on your quality of life? What would you like to achieve? Let's aim towards that. It's not always about having no more dizziness, no more vertigo, no more headaches, but having, maybe that's good if you can have 0 symptoms. But I think for most patients, even if they have some symptoms, but they are able to get back the life that they want, that's good enough. It's empowering patients to be in control of their illness. Fortunately, most of my patients, the endpoint is not about walking on the tightrope, right? So the goals are more achievable for a lot of my patients. Treatments to consider, I think for us, where there's a strong element of emotional, psychological stress, I think just being able to share it, talk about it with people that we trust, family members, friends, could be other groups, church groups, temple groups, other social groups, being able to let it out goes a long way in healing the mind. Sometimes we may need professional help. It may not always be seeing a psychiatrist straight away because, like it or not, there's still a strong stigma about seeing a psychiatrist. But I think most people are happy to see a counselor, and Bppv Center, they have fantastic counselors there. So one of the resources to consider, or a psychologist, they are allied health professionals, not psychiatrists. They won't give you antidepressant, but they are very good at helping patients deal with stress, anxiety, depression. Okay, strategies to improve your sleep, because unfortunately, when you have psychological, emotional issues, right, sleep is the first thing that gets affected. What can we do? Sleep hygiene simply means doing the right sort of thing before you sleep, not being on the computer just before you sleep, reading late into the night, playing computer games, because those things are stimulating to the brain and it will make it harder for you to fall asleep. Mindfulness practice, again, something that Bppv Center promotes. I think that's a great way if you can practice some mindfulness before you at bedtime to relax the mind. Relaxation, any form of relaxation therapy. Melatonin is a herbal supplement that you can buy from the pharmacies. You don't need a prescription. not herbal, sorry, it's a hormonal supplement, because melatonin is the hormone that our body produces naturally to help us fall asleep. And on a short-term basis, you can take this to help you fall asleep, but not as a long-term solution, right? And even acupuncture, right? I like to be holistic in how I deal with my patients. And I don't think Western medicine, we have all the solutions, right? We do have sleeping tablets, but no, we don't like to put patients on sleeping tablets, and patients don't want to be on sleeping tablets either. So acupuncture, and in particular, learning about the acupressure points so that patients know where to press to help them fall asleep. Hint is somewhere on the ear, the acupressure points for falling asleep. So TCM, I'm happy to refer my patients because whatever helps them, right? Dietary measures, avoiding all the triggers, the food triggers that triggers your migraine, good hydration. Migraine medication, there are two types, preventative to prevent the migraine and relieving the migraine. Which one to go for? Depends on how frequent your symptoms are. If you're getting giddiness and headaches every day, right? Severe, you cannot go to work, you're on MC all the time, you probably need something to prevent it. If you get 2 or 3 attacks a year, you probably don't want something to prevent it, right? You don't want to take something every day to prevent something that happens 2 to 3 times a year. But then you can have something to relieve the headache, relieve the giddiness, vertigo, as and when it happens. Okay. So some of the common problems that I'm seeing, okay, coming to the end of my talk now, is that some of my patients have frequently been given medication to suppress the vertigo. These medications would fall into the group of what we call vestibular sedatives. And some of the examples are given here, like Stugeron, Stametil. They work to suppress the vertigo by suppressing the vestibular signal, right? The signal from the ear to the brain. And they also suppress the brain. They're great if you're having severe vertigo, you're vomiting, regardless of what's causing it, right? It could be migraine, it could be vestibular neuronitis, it could be Meniere's disease, great. Temporarily, for a day or two, up to 5 days, suppresses the vertigo, stops the vomiting. But this group of medications should never be used long-term, especially when the diagnosis of your vertigo have not been established. Then you are taking the medication to treat the vertigo without knowing what is causing it. And the trouble is, if you take these sort of medications long-term, you then substitute the vertigo. You don't get vertigo, but you have a chronic sense of imbalance. Your risk of falling is increased, and we don't want that, right? And you don't want that either. And other side effects, tiredness, sleepiness, and you can end up having abnormal movements. Definitely, you don't want that, right? So I think this is probably my last or my second last slides. So if you have recurrent or chronic dizziness or vertigo, right? Please see a professional to get it evaluated properly. Conditions like Bppv, Meniere's disease, vestibular neuronitis or labyrinthitis that I mentioned earlier, I think I would say all ENT doctors and perhaps many GPs are confident to diagnose and manage these conditions. And that's the reason why I'm not focusing on these conditions, right? Usually my patients with these conditions, they are well managed. It's the ones with vestibular migraine. It's not an easy condition to diagnose. So it's certainly a diagnosis that can be considered. If the diagnosis has never been clear for you, you'll be having dizziness for years or decades, and you've been given multiple diagnoses, multiple medication, and you never quite get better, at least long-term, temporarily you're better, but then you fall back again. This may be the condition that you have. But also important to mention that just because you have migraine, right, you have migraine headaches, doesn't mean that if you get dizziness, it has to be vestibular migraine. Because if you got migraine, you can get Bppv. It's possible, right? So I'm not saying that every case of giddiness, you got migraine, you must have vestibular migraine. So every patient needs to be treated properly, a proper history, a proper clinical evaluation, examination to come up with the diagnosis. Okay. And I'd like to end, this is my final slide now, with a dedication to all of you, my patients, right? Because what I've learned, how I become good and confident in managing patients with dizziness is because of all the patients, the hundreds, the thousands of patients that I've seen in my career. I've learned something from every one of them. And this is me saying thank you to all of you, right? So this is an ode to my patients. Patiently, thou had waited for me, opening up thy hearts, healing seeketh thee. With compassion, loving kindness and empathy, with respect, gratitude, humility, and sincerity. I will try my best for thee, for greatest teachers thou hast been for me. Okay, and that's my last slide. I'm open to questions. Thank you.
Thank you very much, Dr. Ho, for the excellent presentation, and it's been so informative. And your caring nature definitely came out very strongly. And I do like to let everyone out there know that his caring nature is a very sincere and authentic one. I have seen Dr. Ho myself, and often when it's people I recommend or people needing other specialty, he's also very kind to make recommendations. So I'm very touched by his sincerity, his authenticity, and definitely his true sense of care. And that's why he's on our board. I mean, that's what we need, people who are truly caring and serving from the heart. So we're very privileged to have Dr. Ho in Singapore looking after us in the community.